live by 3:30, so send it to myself, run to the car.
Just a flag that we're live on YouTube. Testing 1, 2, 3. Test YouTube. Audio 1, 2, 3. Testing 1, 2, 3. 1, 2, 3. Test, test. Testing 1, 2, 3. 1, 2, 3. Oh, cool. Great. Do you want me to hold on to those?
I'll just put them here because I'll need my pen. So, make sure this is working. Okay, we good?
Yep, we're all set.
Okay. Good afternoon, and thank you for joining today's briefing. Our Chief Medical Director, Dr. Singhal, will not be joining us today, so I'll start by sharing the most recent monkeypox updates and then follow that with updates on our COVID-19 metrics. I'll also review the results of a recent data analysis that looked at death rates in LA County and how they've changed throughout the pandemic. Because we know that many people are still impacted by COVID-19, we'll end by talking about the therapeutics and boosters that are currently available. I'll take the first slide. So starting with a brief update regarding the monkeypox outbreak. As of today, there are 2,149 confirmed cases of monkeypox reported in LA County. 120 are reported in the city of Long Beach, and an additional 29 reported in the city of Pasadena. New cases in LA County, as you can see here, continue to plateau and actually decline. They also continue to be primarily among gay and bisexual men and other men who have sex with men, and the median age of cases remains at 35. Since most people with monkeypox have had mild to moderate illness, our hospitalization rate remains low, with 5% of cases in LA County, 100 individuals hospitalized since the start of the outbreak. As we continue to respond to the outbreak, it's helpful to look at the pattern of cases over time. The latest monkeypox case trend data by episode date is shown here on our EPI curve. The blue bars indicate the daily case numbers, and the pink trend line indicates the 7-day daily average number of cases. As you can see, there's been a substantial decline in monkeypox cases. 2 months ago, our 7-day average daily cases was at 35. A month later, this declined to 19. And as of October 8th, this has dropped to an average of just 5 daily cases, which is the lowest 7-day average daily case number that we've experienced since early July. These declines are consistent with a slowing growth rate in the United States and in a number of other countries. We're encouraged by these declines, and we continue to work with partners to ensure that residents have access to timely and accurate monkeypox information, as well as vaccinations and treatment. There is mounting evidence that shows that vaccinations and antiviral treatment are key protective measures that can protect individuals and help to slow the spread of monkeypox in LA County. We have an ample supply of the monkeypox vaccine, and with the help of many healthcare providers and community partners, LA County hit a milestone in the first week of October, administering over 100,000 vaccine doses. There are options for getting vaccinated at sites throughout the county. You can walk up to a public vaccination site, or you can go ahead and make an appointment at myturn.ca.gov to be vaccinated at a nearby community partner or provider vaccination site. A list of all the sites posted on our monkeypox website, but you can also call our call center 7 days a week, 1-833-540-0473 for referrals. In addition, the antiviral medication that's used for people with severe illness, it's called TPOXX, readily available here in the county. It's available for patients at over 500 sites. So there's not an access problem getting TPOXX in LA County. Residents, providers, and partners can visit the monkeypox website, ph.lacounty.gov/monkeypox. There you can access helpful educational materials. They're in multiple languages. You can look at our dashboard. You can look at the vaccination data we have, at the TPOXX data, and we update this every Friday. Next slide. I do want to go ahead now with a situational overview on COVID, and I'll start by looking at the updated trend lines for cases, hospital admissions, and deaths in LA County. In this figure, that green trend line is a 7-day average of the number of cases reported daily, and we measure it using the vertical axis on the left. During the past week, an average of just under 920 cases were reported per day. This is a very small, about 3% decrease from the 7-day average of 950 cases that we reported per day last week. The 7-day average for the number of daily hospital admissions, that's the orange line, it's measured on the vertical axis on the right. This also has a decline that's slowed, as you can see, since the beginning of October. This past week, there was an average of 66 admissions per day. That's down from 73 admissions per day last week. The blue line on the slide is the 7-day average number of deaths reported daily, and it also is measured by the axis on the right. This metric, as you can see, has really stayed fairly steady. We have an average now of about 10 to 12 deaths reported per day, both this week and last week. I do want to extend my condolences to people in our community who have felt and continue to feel these losses. I know that this impact is great, and I send hope for healing and peace. Take the next slide. Using the CDC's community levels framework, LA County remains in the low community level. This is our 8th week in a row. Our daily weekly case rate declined further this past week to about 63 cases per 100,000. I want to note that if this case rate continues to decline, the county would move from substantial transmission, which is where we are now, to moderate transmission in the upcoming days. The values that we're seeing for the rate of new COVID-19 hospital admissions and the proportion of beds occupied by COVID patients also both declined slightly. 8 weeks in the low community level is significant, and it does reflect reduced transmission. Keeping transmission as low as possible, however, requires continuing to take sensible actions, including getting vaccinated and boosted, getting tested when you have symptoms, isolating when you have COVID, and wearing a mask and getting tested when you've been exposed. Next slide. As a reminder, we also track 8 early alert signals that we're monitoring for COVID-19. Since early September, many of our indicators have been classified at low concern. And I'm happy to report this week that the number of new outbreaks in TK through grade 12 school classrooms decreased, and now that metric is also of low concern. Last week, we reported 11 outbreaks in TK through grade 12 classrooms. This week, we're reporting 7 outbreaks. As with all of our indicators, we will watch this number carefully, but we're relieved to see this progress. The number of new outbreaks in skilled nursing facilities also moved this week, unfortunately, in the wrong direction. It's now of medium concern. We have 13 new outbreaks reported. That's up from 7 that we reported last week. I do want to note that at skilled nursing facilities, 1 positive case among a resident is considered an outbreak. We have this low threshold on purpose, knowing that there are people at very high risk for severe infection in these settings, and we want to take every step possible to curb severe outcomes. An outbreak designation means that our outbreak team will be working with residents and staff to try to prevent and mitigate further transmission. Next slide. Last week, we first introduced this graph reporting on wastewater viral concentrations. The blue line is a weighted average for viral concentration across 4 wastewater treatment plants, weighted by the population served by each plant. The treatment plants included are Lancaster, Tapia, Hyperion, and the Joint Water Pollution Control Plant. And the reporting on this trend line started in May 29th and runs through October 8th. For the second week in a row, the viral concentration is about 21% of the peak concentration we saw in July, and that places this metric in the low concern category. If we see this number surpass 30% of the peak concentration, we'll move into a medium concern. And if it's 60% or greater of peak concentration, that would be of high concern for us. You do see that there's a small plateau, and I think that indicates that we're no longer seeing any substantial declines in wastewater concentration, which may mean that viral transmission is no longer decreasing in LA County. We'll have to see. Next slide. As we try to anticipate changes that could contribute to a winter surge, we pay close attention to the weekly reports of circulating virus strains in LA County. The most recently available data shows that Omicron BA.5 continues to be the dominant subvariant, yet it appears to be gradually accounting for fewer sequence specimens. indicating that other variants could become more dominant in the future. For the week that ended October 1st, 88% of sequence cases were BA.5 compared to 91% the week before and about 93% a few weeks back. These changes are small, but they could indicate the beginning of a growth advantage by some of the other strains. We're continuing to track and look at changes in multiple sublineages of the virus. BA.4.6 is represented on the graph by the yellow bars. It increased to almost 6% of sequence cases, up from 3.8% the week before. This is the highest weekly percentage of BA.4.6 that we've seen so far in LA County. BF.7, that's the bright blue at the top of the bars, also increased, and it accounted for 2.8% of sequence specimens in the most recent week. As a reminder, BF.7 is a descendant of BA.5. This week, we added 2 additional descendant strains of BA.5 to this slide, BQ.1 and BQ.1.1. Both of these sublineages are currently at very low levels in LA County, with only a cumulative total of 7 BQ.1 specimens and 3 BQ.1.1 specimens detected so far. We do know, however, that across the country, CDC estimates that this week, BQ.1 and BQ.1.1 accounted for 11% of the cases, up from about 3% 2 weeks ago. BA.2.75, that's the pale green at the bottom of the bars, accounted for 1.2% of the specimens in the most recent week. This is a small increase from 0.5% the week before. We're also tracking BA.2.75.2, a descendant of BA.2.75, but it's remained stable and it accounts for, I think, around 0.2% of specimens per week, and that's been stable for the last 3 weeks. And note that we've only seen about 7 specimens sequenced in total of BA.2.75.2 in LA County so far. We're not reporting any sequence specimens of XBB, which has been spreading quickly in Singapore and has some reported cases in India. XBB is a recombinant of 2 BA.2 sublineages, and researchers at the University of Beijing have found evidence that it can evade antibody protections developed after a BA.5 infection. We don't yet know the full implications of this. Currently, the CDC isn't reporting XBB on their website since it hasn't been detected in at least 1% of specimens nationally. All of these new strains are new versions of Omicron, which continues to mutate to try to gain a growth advantage. Some of these mutations make it easier to evade prior immunity, meaning that many of us can be reinfected even if we were previously infected with a strain of Omicron earlier this year. And while there's no immediate risk, given the relatively low numbers of recently sequenced specimens of these new sublineages in LA County, we do need to be vigilant. Some of these sublineages have a greater evolutionary advantage than their predecessors, meaning that they can be more contagious, they can crowd out other circulating COVID variants, and they can break through protections such as prior infections, vaccinations, and therapeutics. With a virus that mutates often, it's important to track even small changes. The positive news is that the updated Pfizer and Mrna bivalent boosters contain the BA.4 and BA.5 spike protein, and we expect that this will provide good protection against the BA.4 and BA.5 subvariants and the BQ strains that I just talked about. Next slide. One reason we continue to urge everyone living and working in LA County to take common sense precautions is because recent studies illustrate that COVID-19 has had an outsized impact on our health. We recently shared information that showed increased risks associated with repeat infections and associated with long COVID. Public Health just completed a data analysis looking at COVID and non-COVID mortality rates in the county. The analysis looks at 4 6-month periods, January through June, from 2019 to 2022. Using the first 6 months of each year allowed us to include 2022 in the analysis. On the left, you can see the rate of all-cause mortality or deaths per 100,000 people, with the light blue denoting non-COVID deaths and the red representing COVID-related deaths from 2019 to 2022. During the 10-year period that ended in 2019, before the pandemic, the all-cause mortality rate had been fairly stable, and we were actually starting to see a slight downward trend. The most dramatic finding, which you can see on this slide, is that when the pandemic started, the all-cause mortality rate for the first half of 2020 jumped from about 298 deaths per 100,000 people to almost 336 deaths per 100,000 people. And in 2021, it jumped much higher, to almost 400 deaths per 100,000 people. During the first half of 2022, it's dropped back to about 336 deaths, but this is still considerably higher when compared to 2019. You can see by the areas shown in red that the vast majority of these increases in all-cause mortality were due to COVID-associated deaths. But COVID deaths do not account for all of the increase. The COVID pandemic may also have led to more deaths from other causes through delayed care for other conditions, health systems being overwhelmed, or people being apprehensive about potential exposures to the virus. In the winter of 2020 to 2021, we saw that huge surge. That was the first year of the pandemic. And in the winter of 2021 and 22, we had another huge surge with an even higher number of cases. One interesting highlight is that even with more cases in the winter of 2022, COVID deaths were lower in this second winter surge. This is likely because this past winter we had more tools to prevent severe illness. That included boosters, antigen testing, and therapeutics. And although it's not shown on this slide, we also looked at changes in mortality rates within different age groups. While the death rates associated with COVID have been highest among older residents, this analysis found that younger adults experienced a greater increase in mortality rates than older adults when you compare 2022 to 2019. For example, the all-cause mortality rate in 2022 is 29% higher for 18 to 29-year-olds and 36% higher for 30 to 49-year-olds compared to the respective rates in 2019. By contrast, the all-cause mortality rate in 2022 compared to 2019 is 12% higher for 50 to 64-year-olds and 15% higher for 65 to 79-year-olds and 6.5% higher for those 80 years and older. We also found that COVID-specific mortality rate in 2022 among Latinos and Blacks is about twice as high compared to the rate among Asians and whites. Hopefully, this data allows us all to understand that COVID-19 has led to a tremendous loss of life. The full analysis of the comparison in mortality rates, including these breakdowns by age, race, and ethnicity, will be available later this afternoon at ph.lacounty.gov/media/coronavirus/locations.htm. I think it's on the slide. I hope so. It's a lot, but you can call us and we'll help you get to the report. Next slide. We also are able to use this information to compare death rates for select illnesses, including COVID, coronary heart disease, diabetes, and pneumonia and influenza for the first 6 months of 2019, 2020, 2021, and 2022. For each year, the highest mortality rate by cause is shown in the color purple. For example, you can see that in the first 6 months of 2019, this was the year before the pandemic, coronary heart disease was the leading cause of death, with about 51 deaths per 100,000 people. The next year, during the first 6 months of 2020, coronary heart disease was still the leading cause of death. It had a similar rate of about 52 deaths per 100,000 people. And even though COVID had only begun to spread widely in March of 2020, so only really 3 months of COVID that we're capturing here, it immediately became the second leading cause of death for the first 6 months of 2020, resulting in about 28 deaths per 100,000 people. In 2021, as you can see, COVID was by far the leading cause of death, causing almost 96 deaths per 100,000 people, while coronary heart disease continued to be responsible, again, for a similar number of deaths, about 51 deaths per 100,000 people. For the first half of 2022, coronary heart disease again is the leading cause of death, with COVID close behind as the second leading cause of death. Note that for all the years shown, mortality from diabetes and influenza and pneumonia were much lower. So far for 2022, the mortality rate from COVID-19 is more than 4 times greater than the mortality rate from pneumonia and influenza combined. And we have had flu this season, so I just want to note that this is a season where starting in March, we started seeing influenza here. Next slide. To reduce the high death rates associated with COVID, we'll need to do a better job using all the resources available to protect against severe illness, hospitalization, and deaths. While vaccines and boosters play a critical role, therapeutics can also play an important role. There are 4 different COVID-19 therapeutics that healthcare providers have available to treat people with symptoms of COVID. The specific medication they choose to treat a patient will depend on a variety of factors, including the patient's prior medical history and their response to other medications. 2 of the medications can be taken at home orally or by mouth, and the other 2 are given by intravenous infusion or injection in a medical facility. The healthcare provider always needs to assess a patient before these medications can be prescribed and administered. Many people, however, qualify for and will benefit from these therapeutics, and many people may not know that. You may be eligible for medication to treat COVID-19 if you have symptoms and a positive COVID test, and you have a risk factor for developing severe COVID. Risk factors include being 50 or older, having an underlying health condition that places you at higher risk, or being unvaccinated or not up to date on your vaccines. This would include as well people who are pregnant, are current or former smokers, have type 1 or type 2 diabetes, are overweight, or have a history of cancer. If you have symptoms of COVID and you've tested positive, please check with your healthcare provider as soon as possible to review your options. 3 of the treatments are what we refer to as antiviral medications. Paxlovid is for adults and children 12 and older. This medication is taken orally at home and needs to be started within 5 days of seeing symptoms. In clinical trials, it had an effectiveness rate and efficacy rate of 88% in reducing hospitalization or death. Remdesivir can be administered to adults and children as young as 28 days old. Like all of these medications, it needs to be administered as soon as possible within 7 days of symptom onset. This medication is delivered via IV and needs to be administered at a healthcare facility across 3 consecutive days. Remdesivir has shown an 87% efficacy rate in reducing the risk of hospitalization or death from COVID. Molnupiravir is for adults only, and it can be taken again at home in a pill form. Like the other oral medication, Paxlovid, if taken within 5 days of symptom onset, it's effective at reducing the likelihood of hospitalization or death from COVID, but you may notice its efficacy rating is slightly lower. I think you will notice the trend, however, is that the key to all of this is going to be to talk to a provider so that you can start taking these medications as soon as possible if you have symptoms. The 4th available therapeutic is a monoclonal antibody for COVID-19, and it's available for people 12 years and older as a single IV injection. It should be administered within 7 days of symptom onset, and it also, as you can see, has been shown to significantly decrease viral loads. I don't want anybody to misinterpret these efficacy rates. They're not really a ranking of which therapeutic is most effective because the medications were tested at different times with different variants present and on different populations. But I think the takeaway message is that they're all effective in fighting COVID-19 and protecting those who have a higher risk of severe disease. And I want to also note the treatments aren't a replacement for vaccination and getting boosted. The best way to avoid severe symptoms and the potential of long COVID is to do everything you can to avoid getting infected in the first place. However, we all know breakthrough infections happen, and these medications are invaluable in our toolkit to fight severe outcomes. Next slide. Throughout the pandemic, the residents that have been hardest hit have been those living in areas with a lower level of health resources, with greater risks to their health and with fewer resources available. As a result, we've worked hard to assure that life-saving therapeutic medications in LA County are as widely accessible as possible in communities that historically have the least health-affirming resources. This slide shows the number of courses of oral COVID therapeutic medications that have been administered and those currently available around the county, using the Healthy Places Index to group communities. The Healthy Places Index ranks the health security of a geographic area by assessing multiple factors that affect health and life expectancy. Communities that are in that first quartile of the HPI index have the least health-affirming resources. Those in the fourth HPI quartile have the most. You can see along the top row, almost 50,000 courses have been administered, and almost 30,000 are currently available in our most under-resourced communities. In these same neighborhoods with a higher burden of disease, there are 43 test-to-treat sites, which are places, sort of one-stop shopping, where people can speak to a provider or a pharmacist if they have symptoms. They can get tested if they haven't been tested yet, and if eligible, they can get a prescription to treat COVID all in one place. Per the latest report from providers, over 85,000 doses of oral therapeutics are available right now in LA County. So we have no shortage. Next slide. For those at higher risk for severe illness, there is a safe and easy way to get consultation, care, and a prescription for treatment if you have COVID-19 symptoms without ever leaving your home. Telehealth allows you to speak with a provider using your phone. If you're eligible for treatment and your healthcare provider recommends and prescribes it, a prescription can be called into your local pharmacy or overnight shipped to your house. Your regular provider may have telehealth services available, but if they don't, or you don't have a regular provider, please call the Public Health Telehealth Service at 1-833-540-0473. This is open 7 days a week from 8 in the morning to 8:30 at night. The Public Health Telehealth Service and medications are offered free of all charges. A COVID-19 infection can hit hard, and we want to make sure everyone knows that this option is available. You don't have to leave the house, you can rest and recover, and you'll not risk infecting others. The important thing is that you contact your provider or you use our telehealth service as soon as possible after your symptoms begin, especially if you're at higher risk. Again, these therapeutics will work best when taken as close as possible to when your symptoms begin. Next slide. Before closing, I do want to do a brief update on information on the available fall boosters. To note that as of yesterday, Novavax was approved by the FDA to be used as a booster for adults. Therefore, there are now 3 manufacturers for booster shots available, and I encourage everyone to consider getting this booster dose as soon as possible, especially before we get into the winter months. Pfizer and Moderna both offer bivalent mRNA boosters that are formulated to provide protection against both the original strain of COVID and the Omicron variant. Novavax is a traditional protein-based vaccine similar to hepatitis B and our shingles vaccine. It's formulated for the original COVID-19 strain. However, it will likely provide some protection against Omicron, and it's a good option for people who are unable or unwilling to take an mRNA vaccine. Novavax is approved now for boosters in adults. For children as young as 5, the Pfizer updated booster is available, and the Moderna fall booster is available for children 6 and older. 2 months after your primary series or your last booster dose, you're eligible for the Pfizer or Moderna new booster vaccine. This increases to 6 months if you want to go ahead and get the Novavax booster. You can mix and match all 3 manufacturers for the boosters and the primary series. The important thing right now is that you get vaccinated and boosted when you're eligible. In closing, I appreciate that the risk for transmission of the virus in LA County has significantly declined these past couple of months. For many in our community, this makes it easier to engage in the activities we love with less fear and concern. I am, however, also aware that there are hundreds of thousands of residents in LA County who remain at elevated risk for serious illness should they get infected. Many of these individuals are our family members, our coworkers, and our neighbors. We have tools that, when used by all of us, create an additional layer of protection for those at highest risk. I hope that as we get closer to the holidays and the colder weather and more gatherings, each of us can be sure we continue to do our part by staying home if sick, getting tested when exposed, ill, or gathering indoors with others at elevated risk, and primarily taking advantage of the new boosters that protect against Omicron. Thank you, and I'm now able to take your questions.
We'll open it up for questions. Ron Lynn, LA Times, here in person.
There's been some confusing guidance from CDC on when to get the bivalent booster. We've heard don't get the booster until at least 2 months from their last shot. But others, like parents whose adolescents who got their last monovalent booster in July, are wondering if they should wait for a few more months. Also, the CDC says you can, quote unquote, may want to wait 3 months from the last illness before getting a new booster, but then we saw how the Pfizer CEO got reinfected within 3 weeks of his last COVID illness and hadn't gotten the updated booster before he got infected the second time. What's your advice for people?
Yeah. I mean, I think this is a great question, Ron. I think it has a lot to do with your own risk and what kind of activities you're engaging in. For sure, for people 50 and older, for people with underlying health conditions, for people who have a lot of exposures, I recommend not waiting. I mean, particularly because we're now in October. We're actually almost at the end of October. And you do want to have maximum protection as we enter into our, sort of our fall and winter, knowing what we've witnessed these last 2 years. So there's no point for people at higher risk to be waiting. It is really, at this point, assumed that you're going to have a lot of protection from the new fall booster that will last for a few months. I know people are feeling like, I want to maximize my protection for when I need it most. But I think we know, first of all, the boosters are going to be highly effective against the worst outcomes, and that will be durable for many months. And I think where people have questions is when will it work the best to help prevent transmission of an infection. We don't have final data on this, because we've just started using this booster. But if you look historically, I think you'll have some decent protection for a few months. And the most important thing is to be well prepared for the potential of higher rates of transmission in the community. So you want to go into that with as much personal protection as you can. For people who have been recently infected, because I think that's the group where there's the most confusion, if you're at highest risk, don't wait too long. Again, as we enter into a time period where there's likely to be a lot more transmission in our communities, you want to get the additional protection. But I think for most people, having been recently infected really does boost your immune system. Unfortunately, it's different for each person about the durability of that immune boost that you're going to get from having been infected. Which is why for those at highest risk, we recommend going ahead, assessing what activities you're going to be doing and getting that booster within 2 months of your last booster. But I can understand where some parents are saying, my child was infected in July or August. We're going to be doing a lot of traveling. I might want to wait until we're closer to travel again. I recommend at this point before Thanksgiving, if you want to maximize protection, for the Thanksgiving holiday, you go ahead and get boosted by the end of October, the beginning of November.
For people who are trying to time out how long they might be at risk after going to an event, what's the latest on how long it can be once you've been exposed to when you're contagious, when you know you're in the clear?
Yeah, it's a great question. I think this is where sort of what variant infected you or you were exposed to is going to make a difference. CDC is noting that it seems like the time from exposure to coming down with a positive test or symptoms is shorter. But we know that the period that you still need to wait for that incubation period, it's at least, you still need to wait those 10 days. But I do think if you are watching the experience of many people right now, it seems that people are ending up testing positive and developing symptoms quicker. I want to note that the big exception here is that some people develop symptoms and test negative for quite a while before they actually end up with that positive test result. Many of those people are people who are fully vaxxed and recently boosted. And so while the infection is in fact creating some symptoms for them, it is not necessarily at a viral load that shows up on antigen tests in particular. But my sense is that it could happen quicker. I think everyone should note that you can still end up infected within that 10-day period. So, I know people are saying, day 5, I'm not infected, I tested negative, I'm good to go. And I think the likelihood is that you probably are not going to end up getting infected, but it's not a certainty at all. The incubation period is still at least 10 days. And we ask that people keep their masks on for the other 5 days because of that.
I know that you can get the flu and booster at the same time, COVID booster, but if people want to split them up, which one would you recommend first?
Well, we have, one reason why we tell people to get them both at the same time is everybody should be getting those vaccinations now. Flu is definitely circulating here in LA County. We've definitely seen increases. I think, as a matter of fact, we have a higher percentage of specimens testing positive for flu at this point in the year than we usually have in a normal influenza season. So flu's here. So please, go ahead right now, get that flu vaccine because you're going to need that protection. You don't need to wait in between. So I don't think it really matters if you get your flu shot today and you get your bivalent booster tomorrow. But I would urge people to do them both either very close together or at the same time.
And regarding BQ11 and BQ1, do you think the current vaccines will protect against it or not so much?
I'm hoping they will. They are sublineages of BA.5. So our sense is that there should be very decent protection.
And finally, San Francisco says it'll end its monkeypox state of emergency after Halloween. Are you reassured how things are going with monkeypox here, or do you think there could be another wave like COVID?
I'm very optimistic with monkeypox that we've really dampened transmission. I think we have a lot of work to do still, though, because when we estimated the number of individuals in LA County who may be at higher risk for getting infected, that number was somewhere between 150,000 and 170,000, and we have about half of those folks that have been vaccinated. I think a lot of people have changed their behavior, and I applaud that, and that was absolutely essential. But it's also really important that people continue to avail themselves of the vaccine.
Adam, any questions on that?
Yeah, I was going to ask about the monkeypox. What do you attribute that decline to?
A lot of people got vaccinated. A lot of people, in fact, made behavior changes that I think made a difference. There's increased awareness of how you can get infected and what you can do to prevent transmission. And it remained really contained in one of our communities when we didn't see a lot of spread. I think if we had seen a lot more spread, then perhaps we wouldn't be where we are now because the messaging was very targeted. And I think that was the right decision. We've always been clear anybody can get infected with monkeypox because it's about your exposure. But when we knew that it was circulating widely among men who were having sex with men, it made a lot of sense to prioritize communications and efforts. And I think that worked. But as I said, it's not over. And we're not done with monkeypox. We have an opportunity because we have ample supply of vaccine to increase the level of protection that residents in LA County who are in the higher risk groups can avail themselves of.
Who can get the vaccine now?
Well, the vaccine is, first of all, widely available. Everybody who is in what's considered a higher risk group is now eligible. including people who may be at higher risk in the future. So it's not really based any longer like you engaged in sexual activity with multiple partners in the past. If there's a chance that in the future that might be something you do, you're able to go ahead and get vaccinated as well. Men, obviously, who have sex with men, men who are bisexual, men who are gay, transgendered folks, anybody who is engaged in commercial sex is eligible. People who frequent places where there are large events where people may be scantily clothed, not wearing a lot of clothing, and in close contact are eligible. People who frequent bathhouses are all eligible. There's a small group of healthcare workers, by the very nature of their work, they're eligible. And at this point, I want to note that we don't ask anybody to disclose what's making them eligible in LA County. Like you do not have to say, this is the group I fall in. We give everybody good information about where the highest risk is, and then people can go ahead and just affirm that they are at higher risk and get, and they meet one of the criteria and go ahead and get vaccinated. And again, in the past, it was based on your previous behaviors, but this really changes that and says it's really, if at any point in the future you might be participating in activities that put you at greater risk, you can go ahead and get vaccinated. One group that we really would like to see more people getting vaccinated are people who are HIV infected, just because it turns out that illness severity is closely tracking with people whose HIV infections are not well controlled. So the recommendation is for everybody who's HIV positive to come in and get vaccinated, regardless of gender.
There was also a recent CDC report about monkeypox infecting the eye. Have you heard of any cases like that in LA?
I haven't heard of any. It doesn't mean we don't know about it. I mean, our team works very closely with hospitalized patients, and as on consults. But as you know, there have been hundreds and hundreds of people who have gotten ill, and we don't have that information easily accessible.
We also have two questions sent in by Marla Tejas from Fox 11 News. The first one is, Dr. Spur, you received your booster
I did.
this weekend. How did you fare in terms of the side effects?
Okay.
And then the second one is, now that Governor Newsom has announced an end to the California state of emergency order, isn't it time for the county and city to do the same? And what impact will this have on your health department?
Yeah, thanks, Marla. Those are both great questions. I'll start with the first. I was very relieved to get my booster dose on Saturday. I want to thank the team that vaccinated me. I didn't feel it at all. And I really, besides having a sore arm, I had no other side effects, which was super nice. In terms of the second question, the governor's proclamation of emergency will expire at the very last day of February of 2023. For both the March 4th, 2020 County Board of Supervisors declaration of emergency and the health officer's public health emergency declaration that happened at the same time, that will be up to the Board of Supervisors to determine whether to extend those local emergencies or end them. If the health officer declares a public health emergency, it does need to get ratified by the board within 7 days. So that's why I'm saying these decisions really go hand in hand. At this point, similar to the sense that the governor has, is we're going to need to continue to have additional protections in place to help us get through a potential winter surge. I want to note that many of the currently remaining elements of the governor's emergency executive orders relaxed state procurement and scope of medical practice requirements that allowed for an increased demand for goods and personnel, COVID testing, laboratory capacity, medical treatment, and vaccinations. We were also, the state was also able to, as you know, go ahead with a quick adoption of COVID-19 workplace safety standards. And I do believe these actions really help blunt the impact of the pandemic. So I thank the state and the governor for moving them forward. I am, as I know everyone else is, very much looking forward to continued slowing of transmission. I think we have these bivalent boosters. If we can get more people boosted with the bivalent boosters, we have a really good opportunity to really maximize protections that are now available. And we're hoping that we don't, because of that, experience the severe disease that's been associated with COVID, as well as these huge surges in cases that are so large that they have a tremendously negative impact on the healthcare system. So I think it made good sense that the governor continued these protections for us until the end of February. And I know that here, we will align with the board. The one promise I can make is regardless of whether there are emergency declarations in effect or those have all been rescinded, at the Public Health Department, we continue the partnership with residents, with our workers, with our community organizations, with our businesses, so that we can protect the health of everyone who resides and works here in LA County.
Another question?
Doctor, I have a question on the B.7 subvariant.
Yep, BF.7.
I'm sorry?
I didn't hear you. BF.7?
It was B.7, I believe. Or am
I think it's BF.7.
BF.7.
Okay.
So that's on your slide presentation on the graph. It was the one that had a slightly higher increase, I guess, 37% for this reporting period.
This was on the variance slide. We don't have anything at 37%, any of the new. The only, BA.5 is still 88%. So it's mostly what we see.
Right.
We've had small increases in BA.4.6. And I think the rest were super small. And I think it was mostly BA.4.6, and BF.7 went up a tiny bit.
Okay.
That's that blue, I don't know if we can go back, but it's the blue, bar at the top was BF.7. So you can see how little it increased. Yep.
Yeah.
So,
Yeah,
over
BF.7,
time, but it's,
So
I think.
you don't anticipate a surge with that maybe being the dominant strain maybe later this winter?
Well, I have to look at sort of like what the data is coming out of CDC for the country. And, what that indicates is it's not necessarily BF.7. That's what we're going to be worried about. Every region has been a little different. What we're seeing in Europe is a little different. I think the likelihood is that there will be a new strain that starts crowding out BA.5. How quickly that happens and how much of an impact that has on a winter surge, I can't really estimate at this point. It's, that's why we put this up, because you could see how small these increases have been over a really long period of time. And if we could show you this going back to like what happened last winter and spring, when we started moving from, BA.1, BA.2 to BA.5, 4 and 5, you'll remember like it moved much faster. So whatever's happening here is going more slowly. That doesn't mean that you can't have a massive acceleration of spread if something is able to crowd out, the rest of the variants that are in place, particularly as we get into the colder months. People are going to be inside more. People aren't wearing masks at all. Partly what I think fueled the rapid spread before might have been that, remember, we were all taking off our masks at that time. So, I think it's a combination of what's circulating with the new strains and what kind of protective actions we're taking.
Thank you.
So, but there's no crystal ball here. We just look at what we're seeing and estimate what might be happening. I think some of the variation around the regions is also, how many people have been vaccinated, how many people have been recently infected, and what were they recently infected with. and what kind of protections might people still be taking. It's going to be very important, I think, for the fall and the winter, what people are doing in terms of getting their booster doses.
Any final questions in the room? All right. Thank you, everyone.
Thank you.
Thank you.